Okay, so divided this up into 3 different Zoom recordings just because it is a 2-hour lecture, which is a lot to listen to all at once. So we're going to start with chapter 15, which is your culture and ethnicity. These are learning outcomes that you can find in the book. These are the key terms. I'll use most of these in our lecture, but some of them you might need to look up in your book as well. So we're going to start off with culture and ethnicity. So what is culture? Culture is defined as a socially transmitted shared behaviors, patterns, beliefs, values, customs, life ways, arts, and all other products of human work and thought characteristics of a population of people that guide their worldview and decision making. Then we have ethnicity. So ethnicity is a person's identification with or membership in a particular race, national, or cultural group, and observations of a group's customs, beliefs, and language. The United States is considered a multicultural society. We continue to see a trend of increasing immigrants. Some projections indicate that the United States will soon become a majority minority. And what this means is that we're going to have so many different cultures that we're not going to have just one majority culture. As nurses, we need to understand our patients' cultural values so that we can provide them with good care. We also need to be aware because we're going to need to understand their cultures so we can do teaching, supervising, and role modeling culturally competent care for them as well as other people that we might work alongside of. So the benefits to having culturally competent care is that it's going to increase your patient's safety and satisfactions, and it's going to reduce healthcare disparities. When we talk about healthcare disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. Healthcare disparities include mortality and life expectancy, the burden of disease, many of which are listed here, also mental health, uninsured or underinsured, lack of access to care. Health disparities can result from a multiple of factors. It can be due to poverty, environmental threats, inadequate access to healthcare, individual and behavioral factors, and educational inequalities. When we talk about the burden of disease, some of this is related to systemic inequities based on race or ethnicity, and some are genetically predisposed. We can also look at things like dietary practices and other cultural values that can impact somebody's health. Page 298 to 299 in your book kind of touches on a lot of that. So when we talk about what's meant by culture, it's important for us to know that we're not going to be able to learn every cultural practice of every group, but it is important for us to learn about the cultures that we're going to most often encounter. What's culture? So culture is what people in a group have in common. It can change slowly or it can change rapidly. It's going to be learned through life experiences, and it can be taught through values, beliefs, and traditions that are passed down from generation to generation. This can be formally, so in schools, or informally through family. Some generations will totally adopt the values and beliefs and traditions of their elders. Some might adopt them partially, and some might completely move away from the teachings entirely. Culture is shared by its member. Culture norms are shared through teachings and social interactions. It can be dynamic and active, meaning dynamic and adaptive. Culture, customs, beliefs, practices are not static. They're going to change over time and at different rates. Cultural change occurs typically as an adaptation in response to the outside environment, and they're complex. Our cultural assumptions and habits are typically unconscious, and therefore it's difficult for members of a culture to explain to others or to identify as different from another culture. So our cultural characteristics are going to be able to provide the members with a sense of identity and a sense of belonging. It's going to be universal, which everybody is included in that culture. And it's going to be dynamic, meaning that they're going to share their customs, beliefs, and practices. And those practices and shared beliefs are going to change over time. When we say that it exists at many levels, we're meaning that it can be at the material level. So it's going to be arts, writing, dresses, and artifacts that the culture produces. And then non-materials are going to be those customs, traditions, language, beliefs, and practices. The values, beliefs, and traditions, again, are going to be passed down from generation to generation. Those assumptions and habits are going to be unconscious to those that are in it. And the culture is going to be diverse. So it's going to demonstrate the variety that exists among groups and among members of the particular culture. So now we can get into ethnicity, race, and religion. So ethnicity is similar to culture in that it refers to groups whose members share common social and cultural heritage that's passed down from generation to generation. Ethnicity is also similar to subculture in that the members of the ethnic group have some characteristics in common that are not shared or understood by outsiders. Ethnicity may include race, but it's not the same as race. Race refers to the grouping of people based on biological similarities, such as skin color, blood type, or bone structure. And then we can talk about religion. Religion refers to an order system of beliefs regarding the cause, nature, and the purpose of the universe, especially the beliefs related to worship of God, gods, or a higher entity. Our concepts related to culture, the first one that we can talk about is ethnocentrism. And what this is that we believe that our culture is the superior culture. And we're going to use it as criteria to judge other cultures with. Then we have socialization. Socialization is learning the culture by immersing ourselves into it. And therefore, by this immersion process, we learn social rules and roles. We learn the behaviors, the norms, the values, and the perceptions of others in that culture. Some common locations where we can accomplish socialization would be family, schools, churches, and peers. In class, I used an example that if you had a strong Hispanic culture in your development and they were throwing a large get together, if you went and socialized there and started learning their behaviors, norms, and values, you would be practicing socialization because you would be immersing yourself into that culture. Nursing in itself is a culture, which we'll talk about later on. But as students, you guys are now being socialized among nurses in their culture so that you have a better understanding, right? So then we can talk about acculturation. So acculturation is a new member of a group or country that assumes the characteristics of that culture through learning process called acculturation. A person who is acculturated accepts both his own and the new culture, adopting elements from each. Then we have assimilation. So assimilation occurs when the new member gradually learns and takes on those essential values and beliefs and behaviors of the dominant culture. Assimilation is complete when the newcomer is fully merged into the dominant culture. So what's a dominant culture? Your dominant culture is a group that has most authority or power to control the values and reward or even punish behaviors. It's usually, but not always, the largest group in a particular area. Then we have subcultures. So subcultures are groups within a larger culture or social system. So when we think about subcultures, people in subcultures have a different experience from those in the dominant group because of status, residence, gender, sexual orientation, ethnic background, education, or factors that unify the group. So if we look at Southern culture as a dominant culture. And then we look at Southern culture, people of higher economic status. Those in higher economic status would be a subculture of the Southern culture. Same thing if we look at people of a different sexual orientation in the Southern culture. So it's just something that's still in the dominant culture. However, it's that smaller group. And then we have the very small groups, which is your minority group, right? And the minority groups are made up of individuals who share a race, a religion, or an ethnic heritage. They usually have fewer members than the majority. And then we have rituals. Rituals are formal, stylized, repetitive actions performed in special places at special times. These actions convey information about participants and are used to inform others about the beliefs and traditions of a culture. Detrimental concepts are something that we as nurses need to be aware of because we do not want to be implementing something that's going to be detrimental or negative to our patients. So the first one we can talk about is generalization. Generalization is a statement, idea, or principle that has a very broad application. Generalizations typically infer or draw conclusions from many factors. They can be positive and they can be negative. We have stereotypes. Stereotypes is a set of fixed ideas. They are unfavorable and they're about members of a group. This is the thought process about the group. Then we have prejudice. Prejudice is the process of devaluing an entire group because of assumed behaviors, values, or attributes. People demonstrate prejudice when they apply group stereotypes to individuals and assume that the people within the group will act in this predetermined manner. Prejudice includes labeling groups or cultures. So we can think of this as that prejudice is going to be the feeling that we assign to the thought of the stereotype. So I can assign lazy to all blondes that are stupid, right? Or I can assign hate. Discrimination refers to policies and practices that are harmful, and we have health disparities, which is a discrimination of a higher burden of illness, injury, or mortality. And then we have healthcare disparities, which is an inequality related to the access, use, and quality of healthcare. We'll go more into that in a few slides. And then we have racism. So racism is an unfounded belief that race determines a person's character or ability, and that one race is superior or inferior to another. Race, again, we discussed it a few slides ago, but refers to the group of people based on a biological similarity, such as skin, blood type, or bone structure. So now we're going to move into our vulnerable population. So we have some examples on the board of what a vulnerable population is, and these are groups that are more likely to develop health problems and experience poor outcomes because of limited access to care, high-risk behaviors, and or multiple and cumulative stressors. Some ethnic and racial minority groups are also vulnerable. An example is that among American Indians and Native Alaskans, there's a higher incidence of diabetes early in life with a higher mortality rate. So vulnerable populations can be considered subcultures of the majority culture group. As the nurse, you need to be aware when we're caring for patients of a vulnerable population, we need to help the patient identify their strengths and resources so that we can provide their care, right? If we don't know what their strengths and resources is, we're not going to be able to help provide the best care for them. So now we can talk about cultural universals and specifics. Your cultural universals are going to be values, beliefs, and practices that people from all cultures share, whereas culture specifics are going to be values, beliefs, and practices that are special or unique to a culture. Our archetypes are an example of a person or a thing, something that's recurrent and it has its basis in facts. Therefore, it becomes a symbol for remembering some of the culture's specifics and is usually not negative. And then we look at stereotypes again. And we know that stereotypes are widely held, but they're very oversimplified and unsubstantiated belief. So it's not valid. And people of a certain race or ethnic group are alike in certain respects. Stereotypes are not always negative. Some may think, for example, that people of a particular heritage are naturally intelligent or naturally athletic. And once we understand all of this, then we can understand how culture specifically affects healthcare. So these are next two slides are things of how culture specifically affects healthcare. First, we want to talk about communication. And we know that communication occurs both in verbal and nonverbal. And it's very easy to understand when a patient's not speaking the same language of you, that we're going to have a cultural communication barrier. But we need to also remember that eye contact, touch, gesture, posture, physical distance, all of that also plays into fact. So although you and your patient might speak the same language, cultural influences how feelings and thoughts are expressed and which verbal and nonverbal expressions all play into a patient feeling comfortable and you feeling comfortable with them. And I give the example of eye contact. So in America, when we make eye contact, that shows trust. If we're talking to a patient and their eyes are darting around the room and they're not making eye contact with us, we might think that the patient's being distrustful, right? But in Japan, eye contact can be seen as a sign of disrespect. So that would just be something that we would need to take into consideration. Is this patient not making eye contact with me because it's a cultural barrier? Don't just assume that it's because they're untrustworthy. Same thing with space, right? We like our personal space. We feel protected. We feel safe, secure, and less anxious and in control. And prior to COVID, where 6 feet of space became the new norm, pre-COVID studies shows that Americans like about 3 foot of space between them and a stranger. In Romania, they like 4.5 feet of space. And in Argentina, they're okay with just 1.5 feet. So think about if you were a Romanian coming into America and the American nurse would kept getting in your personal space, how would you feel? Just like if you went down to Argentina and the nurse has cut your personal space in half. You're gonna feel uncomfortable, and we don't want our patients to feel anxious and uncomfortable around us. The next thing is time orientation. So we need to remember that some cultures tend to be present or future oriented, where others tend to be more rooted in the past. An example is European Americans tend to be future oriented. In contrast, the Native American and Latinos can be present oriented, and they also have deep roots in their past as well. And then we have our social organizations. So what does your cultural patient include as their family? Are they looking at a single parent family unit? Are they looking at a nuclear family unit? Are they looking at an extended family unit? Do they even have a wider organization where their congregation is their family? We need to identify this because that'll be who their support system is. And then environmental control just refers to a person's perception of his or her ability to plan activities that control nature or direct environmental factor. This includes the phenomenon or health and illness beliefs and practices. So then we have our cultural specifics that affect healthcare, more of them. We have our biological variations. So your biological variations is in which people are different genetically and physiologically. And we just know that certain cultures are more likely to have susceptibility to certain diseases and certain injuries. We have biological variations that include our body build, our structure, our skin color, our vital signs, how we metabolize drugs, and all of that will be introduced slowly throughout the program. We also have religion and philosophy. So a person's religion may determine what healthcare is acceptable for them. For example, some religions, like Jehovah's Witnesses, do not accept blood transfusions, and many religions forbid abortion. We also have education. So education influences the perception of wellness and illness and the knowledge of options that are available for healthcare. These in turn affect the person's expectations for care. And technology is also something that we come to expect from our healthcare setting. So if you're somebody who's coming from a city where there's high educations and lots of technology, and you go someplace that's more rural where there's less education and less technology, that's a cultural adjustment that you have to make. Our politics, so government policies like the Affordable Care Act affect healthcare by determining eligibility, allocation of funds, reimbursement for providers, and what the acceptable standards are. We also have the economy. So the condition of the economy directly affects the availability of funds for publicly funded services. It also affects the individual's ability to pay for the healthcare they've received. So the culture of healthcare can be divided into indigenous healthcare system. And the indigenous healthcare system consists of folk medicine and traditional healing medicines. It can also include over-the-counter and self-treatment remedies. And then we have the professional healthcare system. And this is what all the nurses are in school for, right? This is run by a set of professional healthcare providers who have all been formally educated and trained. So our health and illness beliefs, we can have a scientific belief, right? Nursing is a scientific belief. We use our evidence-based scientific for our outcomes and our interventions. We can have magico-religious, which is the belief of a supernatural, almost mystical forces dominates this, which is considered sometimes alternative or indigenous in the United States and Canada. One example is voodoo, which is practiced in some developing nations in Africa, Latin America, and the Caribbean. We can also have holistic, which can be similar to magical religious, but it is focused more on the need for harmony and balance of the body with nature. Nursing as a subculture. So nursing is the largest subculture in the healthcare culture, having beliefs and values that have been formed in part by society at large. These values are listed here of silent suffering as a response to pain, caring, nursing autonomy, use of nursing practice, knowledge, and critical thinking. All of these values are starting to shift as any culture. We still focus on much, but silent and suffering is going away. As nurses, we need to examine and clarify our own attitudes and values to become more sensitive to others. And this is something that, as we talk about understanding the cultural values of your patients, you also need to understand the cultural values of your colleagues. So transcultural nursing is a profession. This focuses on human caring, associating differences and similarities among the beliefs, values, and patterns, life ways of culture to provide culturally congruent, meaningful, and beneficial healthcare. With that, transcultural nurses provide knowledgeable, competent, and safe care to people of diverse cultures. Research in transcultural nursing focuses on discovering or explaining largely unknown and vaguely known cultural care and health concerns. And they do this with two perspectives. The first perspective is the EMIC perspective. And this focuses on local, indigenous, and insider culture. The EDIC perspective focuses on the outside world, especially on professional views. Transcultural nurses are specialists, generalists, and consultants functioning in diverse clinical practice settings and sometimes in schools. They'll assist others to become more sensitive to the knowledge about diverse cultures. They may identify cultures that are neglected or misunderstood and may help healthcare systems assess how they serve or fail to serve diverse cultures in a community. Transcultural nurses are committed to cultural openness, a lifelong commitment that promotes cultural self-awareness and continuing development of transcultural skills. Traditional and alternative healing. So if you have a patient who practices folk medicine is defined as the beliefs and practices that the members of cultural group follow when they're ill, as opposed to more conventional standards. Folk medicine includes both self-treatment and the use of a folk healer. A folk healer is not going to be the same as a physician, a nurse practitioner, or somebody like that. Your complementary medicine is the use of rigorously tested therapies to complement those of conventional medicine. Examples include chiropractor, biofeedback, certain supplements, and acupuncture. These are things that a formally trained practitioner will do. Alternative medicine is defined as therapies used instead of conventional medicine, and those reliably has not been validated through clinical testing in the United States. Examples of alternative therapies are aromatherapy and magnet therapy. So remember, the alternative medicines of aromatherapy and magnet therapy, you can buy it off Amazon. It's not by a trained practitioner. Folk medicine is not a trained practitioner. Your complementary medicines are going to complement conventional, and they're going to be by that trained practitioner. So our culturally competent care, we're going to look at two models. The first model is going to be Prunell's model. And in Prunell's model, we have we can think about the meaning of the different levels. So the first one is unconsciously incompetent. And this is that you're not aware that you lack the knowledge about other cultures. If you're consciously competent, you're aware that you lack the knowledge and you're not doing anything about it. The consciously competent, you're learning about the client's culture, you're verifying generalizations about the culture, and you're providing cultural specific interventions. And then your unconsciously competent is you're fully aware, you're automatically providing culturally congruent care to clients of diverse cultures. You're increasing your consciousness of cultural diversity, which is going to improve the possibilities for healthcare practitioners to provide culturally competent care. So unconsciously competent would be the best one to be. This is Prunell's model. The pie-shaped wedges depict the issues all society and humans share, but they are expressed in ways specific to culture. These domains provide organizing framework for the model. The center of the model is empty and represents that which is unknown about a cultural group. Our next theory is used to guide research that will assist nurses to provide culturally congruent care that would contribute to health or well-being of people using the three models of nursing care, actions, and decisions. Nurses can achieve this goal by discovering cultural care and caring beliefs, values, and practices, analyzing the similarities and differences of these beliefs among the different cultures. So what are going to be your barriers? Your barriers to providing cultural care are going to be your barriers as well as the barriers that the patients have. So first we can have our biases, and our biases are going to be a lack of impartially one-sided, and they can be positive or negative. Then we have our ethnocentrism that comes back. And remember, this is when our culture is going to be the best and we're going to judge other people against it. Our cultural stereotypes, prejudices, and discriminations that we already talked about. Our racism that we've already talked about can be a barrier. Sexism, which is the assumption that members of one sex are superior to those of another sex. Our language barriers, and remember, language barriers is not just specific to foreign languages and dialects, but we also need to take into account our street talk and our jargon. So if your patient has a foreign language barrier and you use your medical jargon, that's actually two barriers coming into play at once. And I always talk about the jargon of like your NPO or that's PRN. Does the patient necessarily know that PRN means as needed? Do they understand that NPO is nothing but an mouth? Those two things patients very often do not understand, but nurses are so used to using that jargon amongst one another that sometimes when it comes down to the patient, we forget they don't understand our jargon. So we need to be conscious of that. A lack of knowledge about the culture and the ethnic values, beliefs, and behaviors of people within the community is not unusual among healthcare providers. It can cause them to misinterpret a client's behaviors. Emotional responses such as fear and distrust, both of ours and our patients, can arise anytime members of different cultural groups meet. If we're aware this may happen, we may be able to avoid this barrier and communicate with our clients more effectively. And then we have our self-knowledge. So self-knowledge is essential in removing the barriers, and it helps us to effectively communicate with our clients. So now let's look at what that nursing process is going to be for cultural and ethnicity. So there's going to be the assessment, and our assessment begins with our health history. We need to obtain at least the information from every patient about their language, their ethnic affiliation and identity, their religious practice, their primary decision maker in their family, and their social support. And then once we have this information, we might have to do a more in-depth assessment with that information. And when we get to religion, if a patient gives you a specific religion, you might have to very much get into their different practices in this assessment aspect. And then our physical assessment. So your physical assessment may reveal biocultural variations to assess and evaluate clients accurately. You may need to know the normal physiological variations among health members of a selected population. And this could be that it's common for them to have an elevated blood pressure, or this could be cultural practices that they normally do to one another. And remember, when we're getting this information, right, about, the patient's language, their ethnical affiliations, their religious practice, their primary decision maker, all of that we want to do on the initial, right? We don't want to wait for there to be a problem to ascertain this information. We want to get it as soon as we can. So when we talk about our nursing diagnosis or our nursing concepts, and we're starting to do the plannings for our outcomes and evaluations, there really are no diagnosis or concepts that specifically address culture. However, cultural factors can be the etiology of various problems. Any of the diagnostic labels or concepts can be used for patients of any culture, provided that the defining characteristics are present. The outcomes we choose, whether standardized or individualized, will depend on the concept we've identified. If the diagnoses are culturally sensitive, the outcomes should be as well. So then we move on to our possible effects a patient's culture can have on their health practices, right? So the first one, the efficacious, this is helpful. So their cultural health practices are going to be helpful to their overall well-being. So bringing ethnic foods that are appropriate for the client's prescribed diet, encourage practices that will likely improve client health and help preserve cultural values related to health. All of this is going to have a positive, helpful impact on their health. Then we have neutral. So neutral is going to be, it's not really going to be helpful, but it's also not going to be harmful. Some people associate good health with eating properly or fasting to cure disease. Some treatment illnesses with prayers or simple foods. There should be no harm in allowing a patient to continue a neutral health practice. You wouldn't want to interfere with these neutral health practices. And then we have our uncertain unknown. So your uncertain unknown is that a client who wants to do a smoothie every day. And that smoothie, we're not really certain of what's in there, but they're using it for good health. Well, we may need to ascertain more information about what's going on so that we either will encourage it or discourage it, right? So we know that certain supplements, certain spices can interfere with, blood thickness and clotting abilities and things like that. So certain things we need to understand more. And then we have dysfunctional. So dysfunctional cultural practices are going to be harmful. And a client may refuse to give a prescription medication to their child. We want to discourage folk practices that may cause harm. In such instances, you should support and enable the patient to adapt to biomedical therapies. And then we're going to be talking about negotiation and repowering soon. And I use the example in class of the dysfunctional harm where there was a patient whose family was collecting their urine and they gave their urine to treat things. And when the child suffered a significant injury, the family wanted to bring the urine in and continue to use the urine as treatment. And this was kind of a folk practice that the family had had. And the nursing staff were not able to obviously continue with that. So with that, we kind of go into our negotiation and our repowering and restructuring. So negotiation is going to be when we look at the client's perspective, and it may differ from ours, but we can kind of negotiate and acknowledge the gaps. We typically do this negotiation when it's going to be folk or odd traditional practices that may be harmful to our patient. Repowering and restructuring occurs when you attempt to change the actions of your patient's entire lifestyle. You would support and encourage the patient to greatly modify their behaviors and to adapt new, different, and beneficial health behaviors while still respecting their cultural values and beliefs. Repowering and restructuring most commonly can occur with dietary consumption. If you have somebody who has a diet and that diet is going to significantly impact their overall well-being, we try to restructure and repowder. So if you have somebody who is, their culture is those home fried, heavy, greasy foods, and you need them to go on to a heart healthy diet, that would be an example of when repowering occurs. So communication with clients of different language. Talking louder does not get the message through. And very often we think that if we speak louder, they'll understand. But the end message here is that you need a professional medical interpreter or translator. It is illegal. We're bound by law to do it. Healthcare facilities must provide language assistant services. in order of preference. So sometimes we have bilingual staff, we can have face-to-face interpretation by trained professionals, we can use telephone interpreters. We need to make sure that whoever the interpreter is, that they can relay healthcare content. So we have to be cautious of family members or lay members that might be bilingual, because they might not actually understand the complexity of medical treatment. So your medical interpreters are going to understand that if you slip and say NPO, they're not going to verbatim tell them NPO. They're going to be able to tell them nothing by mouth, or they're going to ask for clarification so that the patient understands. Developing strategies. So how are you going to improve yourself, right? We're going to reflect. We need to know ourselves. We need to understand our own cultural values and practices and appreciate how they may differ from those held by other people around us. We need to consider how our own biases about people and groups may affect the care that we provide. And we need to learn from our mistakes. Remember, a mistake twice is a decision. We want to keep learning. We want to learn as much as we can about the cultural groups in the community and our work area. We want to study nursing theories and principles pertaining to culture. We want to take advantage of every opportunity to interact with persons of different cultures. We want to learn to accommodate and negotiate when we are able to. We want to collaborate with interprofessionals and consider the cultural role of the family member who makes the primary decisions. And we want to be respectful. The acronym to help you remember all of this can be BALI. So BALI, the B is for be aware of our own cultural heritage. A is appreciate that the client is unique. We want to learn about the client's cultural group, and we want to incorporate the culture when we can. Another one is the live, learn. So we want to like, inquire, visit, and experience. And we want to listen, evaluate, acknowledge, recommend, and negotiate. Your overall concepts to your cultural care is knowing the patient's individual culture will enable the best care possible. We want to always use that certified interpreter. We want to acknowledge the roles of culture's beliefs regarding their health and illness. And we need to understand and find out what matters most to them about their illness and their treatments. And that is the end of this lecture. Thank you very much.